This second panel that we're about to begin, catalyzing widespread informed engagement. Once again, let me remind everybody we are webcast with the most updated technology. And in view of that, please, when you get up to the microphone, just announce who you are so that we can give the appropriate attribution, not only on the webcast, but later on. I'll begin the discussion following the presentations with some very specific questions, and that will open the floor to roundtable member questions, and if there is time, questions from the general audience. By the way, I do encourage questions from the general audience. I think you add a lot to what the roundtable members will think about, so by all means, do not hesitate to come up to the microphone, and I will introduce you. Our first panelist is Dr. Patricia Dykes. Dr. Dykes is a senior nurse scientist and program director with the Clinical Informatics Research and Development at Partners Healthcare Systems and instructor of medicine at Brigham and Women's Hospital of the Harvard Medical School. Dr. Dykes completed formal informatics training at Columbia University, so we have a lot of Columbia students and activists here today, and is experienced in applied clinical informatics, system development, and patient safety informatics research methods. At Partners Healthcare, Dr. Dykes works as a consultant for acute care documentation and conducts informatics and patient safety research. Welcome, Dr. Dykes. Our second speaker, and I hope I pronounced this correct, is Ligia Ricciardi of Clear Voice Consulting. Ligia is an expert and thought leader in consumer engagement and digital health and helps clients from tech startups to large multinational to position themselves strategically and communicate effectively with their customers in the growing consumer digital health marketplace. Previously, Ms. Ricciardi established and directed the Office of Consumer eHealth at ONC, where she led the Blue Button Initiative, which we discussed this morning, and integrated the consumer perspective into meaningful use requirements and other federal policies and programs. The panel's third and final presentation will be by Allison Ryan of Academy Health, where she directs several projects that investigate how new sources of data and expanded stakeholder engagement are helping to transform healthcare and research. Ms. Ryan is the principal investigator on a PCORI contract that actively manages and facilitates collaboration among 50 pilot projects to advance the field of patient-centered outcomes research. Welcome to all three of you. And let me begin with Dr. Dykes. Dr. Dykes.
But give it a run.
I could give it a try, but I don't know. I might be better off with the one that I prepared. Okay. Okay, great. So my name is Patricia Dykes, and I'm really honored to be part of this panel today and to be talking about a topic that's really have been of interest to me for quite a while. So today I'm going to be talking about consumer-generated health information, specifically what are the provider readiness, attitudes, and skills that we need to make this happen. So today, just to give you an overview, we'll start with talking very briefly about what is patient or consumer-generated health information, why is it important, and then specifically, what are the skills and attitudes that are needed by health professionals to interface with consumer-generated health information. And then I'll talk a little bit about a project that we're doing at Brigham and Women's Hospital called the Prospect Project to give you an example of how we are using patient-generated health information in the context of our workflows to try to involve patients in their plans of care. So patient-generated health information is health information that's created, recorded, gathered, or inferred by or from patients or their designees to help address a health concern. And it can come in many different forms. So it could be, in between visits, patients submit health history or treatment history information. They might submit symptom logs so that we get an idea of how they're doing with self-management. At Partners, our patients routinely report patient-reported outcome measures related to cardiac surgery and orthopedic surgery. So I think one of the fundamental characteristics of patient-generated health information is that it's captured by patients, recorded by patients, and then they can share. They can decide whether or not they want to share it. Many patients collect biometric data. They may or may not share this information with their provider. So why is this information important? So it can, when patients are submitting health information that they think is important, it can provide more complete picture of their status than the data that's typically collected in the context of a visit. So for example, if patients are reporting their blood pressure readings over time, this would give the provider a different understanding than just those pressures that are taken during an office visit. Updated medication lists are not only what the provider ordered, but what the patient says they're actually taking. So patient-reported health information can help keep the electronic health record up to date. It also can provide the care team access to the patient perspective related to their problems, concerns, goals, and preferences. And when I talk about our example with the Prospect Project, I will show you how we are using patient-reported information to try to improve care plan concordance between patients and the care team. Patient-generated health information also fosters engagement in self-management and in maintaining improving health. And we know from the research of Hibbard and Lorig that when providers actually pay attention to patient-generated health information, it actually improves engagement and activation. So keeping in mind that provider attention to patient-generated information promotes engagement and activation, what are the skills that and the attitudes that are needed in order to promote this attention? And so one attitude, and perhaps an overarching attitude, is the value proposition of patient-reported health information. So, the question is, what is the fundamental problem and that patient-reported health information is going to solve, and then what are the key benefits? And I think one of the challenges is communicating this to providers so that they're willing to interface with patient-reported health information. And so for us, we think the value proposition is that with the rise of smartphones and mobile devices, that patient interest in health information has really exploded. That patient attention to health information, when the provider is paying attention to, actually improves engagement. It improves activation, health, and wellness. We know from the work of Judith Hibbard that patients who are engaged, they're more likely to engage in positive health behaviors. They're more likely to have lower costs and better outcomes than patients who are not engaged. In addition to the attitudes related to the value proposition, communication skills are also essential for providers interfacing with patient-reported health information. So we heard a little bit about this morning, how important communication is, and not just communication with technology, but basic communication skills. So now, more than ever, providers really need to have expert communication, both face-to-face and then using technological tools. They need to know how to identify decision opportunities, recognize those opportunities and take advantage of them, and have and take the time to engage the patient using decision aids and other types of aids so that the patient can participate in the decision making and understand the information in the level of health literacy that is appropriate for them. So this requires not only a change in attitudes, but this type of communication requires training for many healthcare providers. As you'll see when I talk about the work that we're doing at Brigham and Women's Hospital, another important concept is communicating with surrogate decision makers. So we are using patient-reported health information in the intensive care unit and oncology units. Some of these patients are not able to communicate for themselves, and we engage with care partners to communicate on their behalf. And so that's another attitude and skill set set that we're addressing as part of our program. Another skill set is assessment skills. So we routinely look at health literacy level, patient culture, patient activation. The outcomes of these assessments should really determine the types of tools that we're using with the patients. And if you look at the work that Judith Hibbert has done, she's looked at matching patient activation level with the care plan and using activation level to determine the types of tools and the intensity of follow-up that's required for a patient. Am I doing that?
That's fine, you get it all on.
Oh, okay. Okay. So I think another skill that's really critical is providers having the ability to sort through the data. So, I think that there is a lot of fear about this. Today, relatively few patients are contributing health information to their electronic record and submitting it to their providers, but we really need to adopt our informatics strategies so that we can process big data and we can begin to not only take these data in, but have the ability to display them in a way that they're going to be usable for clinical decision making. There's a lot of debate about whether or not data entered into the electronic health record requires review. And I have to say, in preparing for this, I talked to a lot of different providers, and many of them told me, I don't want to see that Fitbit data, Well, they don't want to see that Fitbit data because they're thinking I have 15 minutes for a visit, and how am I going to process all of that plus do what I need to do? I think that we need a taxonomy is needed to differentiate which data need to be reviewed versus which data patients can just submit. And then when patients do submit data and it is required, and that we do require review, what are the workflows around that? So we talked a lot about the socio-technical components this morning, but I think this is really important. And when I talk about our project in a couple minutes, you'll see that for every piece of technology that we implemented, we thought very carefully about what is the workflow and how can we make sure that any data that's submitted by the patient is going to be considered by the team. So over the next couple of minutes, I'm going to talk about the Brigham Prospect Project. So Prospect is promoting respect and ongoing safety through patient engagement, communication, and technology. It's funded by the Moore Foundation, and I think it's a good example of how we try to address the provider skill set that's needed for processing patient-reported information in an acute care setting. So I think this morning we were talking mostly about outpatient, but I'm at Brigham and Women's Hospital right now and looking at pretty ill patients, so patients who are in for bone marrow transplant and the intensive care unit. So with Prospect, it's a cluster randomized controlled trial we started last June. Our goal is to optimize the overall experience of patients. We hope to minimize preventable harm and reduce unnecessary healthcare costs. There's two components to the intervention. The first is a patient satisfactive model. It's a structured team communication model. And here's where we really try to address with training the provider skills, the communication, and the workflow aspects. And then we also have a web-based patient-centered toolkit. So with the patient satisfactive model, we provide training on communication between clinicians and patients and family members. Part of the training is promoting attentiveness to the patient's needs, concerns, and expectations in real time, engagement of patient and family in the decision making, attentiveness to cultural diversity, and then really looking closely at what are patients' health literacy levels and what does that mean in terms of the tools that we're using with them. So for the web-based toolkit, we have patient-facing tools, and this is the page that they land on where they can report their overall goal for the hospitalization, what their daily goal is. They rate how well they think we're doing with their care. They can also view what the care team's goals are for them, and they can also look at the problems that we had identified, and they can give us feedback about that. They also can message the care team about their plan of care at any time. We also have a set of provider-facing tools, and these were designed to integrate the review of the patient-reported information into the workflow. So this is the interdisciplinary plan of care platform where the team reviews what the patient or the family said over the last 24 hours, and they also agree on a strategy for how they're going to address it. Are they going to go in during rounds and talk to that patient and family? Are they going to do it in family meeting? Are they going to use the microblog and respond that way? This is the safety checklist. The first item on the checklist is where the nurse addresses what feedback the patients and families have given. It's done every single day during rounds. And this is the microblog. So as I mentioned, when the patient can submit questions or concerns at any time, the care team's able to use the messaging functionality first to communicate with themselves to get on the same page, and then they can communicate back with the patient, again, either in person or using the microblog. So, I think that we've learned quite a few. We've had a lot of challenges throughout this project. It's still ongoing. We have many lessons learned. I think that overall, the implementation of the toolkit, along with this patient satisfaction model to really look at the communication and the other types of skills that are needed by the providers for the technology to be successful, was, I think, a reasonable approach. We still, despite that, we have some challenges. We do have some incapacitated patients, not necessarily just the elderly. We have a lot of elderly that use the toolkit. Some cannot. What we do is engage the care partners to try to help them. Clinical workflow integration, we've done a pretty good job integrating with the teams within the hospital, but we're really trying to get those non-localized providers and consultants, and that's been more of a challenge. Managing a multidisciplinary plan of care, this traditionally is not done well. We put the patient at the center. We think it's working pretty well, but we have room for improvement. And then making providers understand the value of this patient-generated health information. This was a major barrier before we went live, and we have been working on it since. So just in conclusion, we think that patient and consumer-generated health information can be used to inform care decisions and to promote shared decision-making. It's really important that we first recognize the value of patient-reported health information and that we consider what the impact's going to be on workflow and address that as part of the project. Attention to provider readiness and logistical skills are key to success, and implementation is not without real-world challenges. So, we had a lot of stakeholder involvement in preparation before we went live with this project, and that has really helped us quite a bit throughout the project and continues to. And before I end, I just want to thank my team members and some of my colleagues who I consulted with when preparing this presentation. Thank you.